Dr. Ayeni, good morning.
Hello, good morning.
Good morning, Dr. Ayeni.
Yes, good morning. My screen went blank. I'm just in Zoom. So I thought there was a message initially that the bandwidth was small, was low. So I thought the host was trying to do something about it.
Okay, it appears the presenter is ready to go. Can we start?
Okay, sure. I don't know. Is it possible is there something the host can do? Should I leave and relog in because I'm just seeing Zoom. There's nothing. I'm not seeing any other thing.
Yes, sir. Likely is the network strength.
Okay. So how do I go about it? I should leave and relog in.
Yes, sir.
All right. Thank you. I think the presenter, if he's ready, can go ahead, please.
Good morning, consultants, senior registrars, residents. This morning, we're discussing this question. A 50-year-old lady who presents with progressive diplopia and visual loss. This started in the left eye, but has progressed to the right eye. Findings on clinical examination included ptosis and lid retraction. So I'm to discuss the management of this patient. So the question was looking pretty straightforward. When I started off, I realized it didn't look as easy as it seemed. But I'll try and discuss it using this outline. I don't know if, okay. Why is it, okay. So all right, I'll discuss it with this outline. I'll introduce briefly history, taking general examination, systemic examination, ocular examination, then the differentials of what the possibilities could be in this lady who is presenting to my clinic. I would like to investigate her to roll out a few of the differentials and pick the most likely diagnosis and treat and describe the prognosis of the most likely diagnosis, follow her up and conclude. So we're giving as an introduction the age of the patient, which is very relevant in this case, because middle-aged people are at increased risk of various causes of ptosis, as we're going to see. Females are have slightly more increased prevalence when it comes to all the causes of ptosis. It's slightly common in females than men, as we're going to see in our discussion. So all these are very relevant salient points I was giving already in the history. And the fact that it was a bilateral cause of diplopia, first of all, and visual loss. I didn't quite understand if both happen at the same time, but I tried to discuss it, bearing in mind that the patient has both diplopia and visual loss, which could be progressive. Because the progressive probably describes the diplopia, but I'm not sure if the progressive was describing the visual loss. But we're told it's on the left eye before the right eye. And the clinical examination finding that were given to us was ptosis and lid retraction. Usually, ptosis on its own can cause lid retraction because once the globe is ptosed, the lid invariably is retracted up. But there are more common causes of lid retraction, as we're going to see. So I'm going to go straight ahead to discuss the management of this patient. And with every management, start with a detailed history. I'd like to know the name of the patient because we're going to request for investigations and you want to know what the name of the patient is, at least identify the person. People usually like when you call them by their name also. So the age of the patient is very important because she's in her 50s. She's female. Some causes of ptosis are common, usually in the third decade of life of middle-aged females. Her race and ethnicity is very important because, for example, prognosis of certain causes of ptosis worsen in different races. Like thyroid eye disease is worse in Asians and Caucasians compared to Blacks. Her address will be important just in case there's any need for correspondence or follow-up if there's need. Our occupation is very vital because you're already having visual loss, and that visual loss might be relevant if she's someone that usually has a lot of visual needs at her place of work. Religion is just for baseline, but also for in case patients who decline treatment as a result of their religious beliefs, maybe blood transfusion or IV drug use. Her hobbies and lifestyle, her vision will definitely be important because if her vision is bad, as she's already presenting with, it will affect her hobbies and lifestyle. Whether she's married or single is also relevant because it shows that she may probably have social support, and she's a female. Ptosis causes aesthetic disturbances and probably some anxiety. So if she's single, that will really be worrying her and worry her a little bit and maybe affecting her quality of life. Dictionary level is also important because it will help to know her level of education and help to see if she can understand in English language or she requires an interpreter or whether all the instructions will be given to her in local dialect. For the progressive bilateral diplopia, we'll say on the left and now on the right, I'd like to ask her how it all started, whether it was sudden in the onset or whether it was insidious or rapid progression, because it's important that we know the time course for the various, for the diplopia, because it helps us whether it's an inflammatory cause or whether it's a vascular lesion that's increasing in size, whether it was related to trauma or whatever the preceding incident was and how it has progressed, even though it progressed on the left, then on the right. Then the duration of this symptom, surely have diplopia, is important because it helps us know if it's an acute event, if it's less than 3 months, or if it's a chronic event, because the common cause of unilateral and bilateral ptosis is thyroid disease, and the thyroid disease has different phases. I want to know if she's in acute phase, where it's been there for a year or two, or more, where she's in acute phase, maybe 1 to 3 years, or more than a chronic phase of thyroid disease, which is 3 years and above. Then they've already told us that she had it in the left eye, then on the right eye. So, but I want to describe her to describe the diplopia to me and ask her if the diplopia is monocular or binocular or a little bit of both. Binocular diplopia is usually of refractive origin and a problem with the media, and it's described as diplopia that is present when either eye is covered. Usually this diplopia is as a result of different images forming on the retina as against a problem with fusion and in binocular diplopia. Because in monocular diplopia, refractive media are probably splitting the rays and forming different images on the retina. That way the person is perceiving 2 images as against the binocular, where both eyes have to be open for the person to perceive double vision, and when it covers either eye, the double vision goes away. Monocular diplopia can be differentiated from binocular diplopia if the person improves the pupil or glasses. So I'll ask her if diplopia is helpful with glasses, or if she blinks from dry eye, if that helps her in any way. So I just want to differentiate whether the monocular was monocular or binocular diplopia, or if she has a little bit of both. I'd like to ask her, is the binocular or diplopia most likely binocular in this case? Whether it was worse at distance or near, and how far and how are the images aligned? Are they aligned side by side or one on top of the other? It's very important because it helps us to know if it's neural origin and which of the extraocular muscles have been affected the most. So for horizontal muscles, probably the lateral, medial and lateral recti, and vertical muscles will be superior oblique or superior rectus muscles or inferior rectus, as the case may be. So I'd like her to tell me also the distance between the 2 images. Are they just lined one on top of the other? Are they ghosting images, or it's far apart? That will also help me tell me the chronicity of the diplopia and the variation of the diplopia with gaze, like when she looks up, because most people are worried if they have diplopia in primary gaze and in reading position. So I want to know if the images come together as she tries to read, or if they split more, or how it varies when she looks up or looks down, to the right or to the left. If there's any position she finds that there is no diplopia at all. These are all important to identifying the etiology and the particular extraocular muscle involved. I'd like to ask her if any preceding events before she notices diplopia. Do you have any trauma or anything at all that she felt was important, any headaches, severe headaches, nausea, vomiting, anything that she thinks might be helpful, any whooshing sound in her ears, is there any variability in this diplopia? Is there any time it gets better? Does it get worse towards the end of the day? Is there anything that she knows that it varies with either time of day or I think there's any preceding trauma? Let's just want to find out if there's anything preceding this diplopia, or ask her if there's any headaches and crossing of the eye. She noticed that her eyes are either drawn out or crossed in or up or down. Maybe when she looks at the mirror, or has anybody ever told her eyes are crossed? And how long has all this been? What is the temporal relationship between the crossing of the eye and the diplopia? Whether she noticed the crossing of the eye first, or whether does it drift away and come back, or just drifts away and doesn't come back? She has any abdominal head position. This may be difficult to tell us because it is not a long-standing diplopia, because we were not told in the question how long she had the diplopia for and at what point she was presenting to me. We were just told it was progressive. So has she developed any head posture to adapt to the diplopia at this point? Did she notice any drooping of the eyelids at this point? Does she think that eyes are bulging forward? Obviously, the question tells us that there's diplopia, there's ptosis. So I suggest that I suspect that she'll have some bulging of the eyes. She have any roving eye movements or poor vision. All these are already been told in the examination, but I'll just find out if she has any of these. So she didn't notice any aggravating or relieving factors with regards to the double vision. She knows if anything makes it better or anything makes it worse. Now, I would like to just ask a few more questions about the bulging of the eyes, which I suspect she might have, because the examination findings already told us that she had ptosis. So I'll ask her if she's painful, the bulge on the eye is painful spontaneously, or does it pain when she moves the eye on either side or up and down? Does she have any photophobia? Did she have any, okay, she already has visual loss from the examination findings given to us in the question. So I asked her, is the visual loss preceding the bulging or after the bulge, or was it at the same time, or just a temporary relationship between either of them? So if she had a ptosis for a long while before she had the visual loss, then it most likely because of complication of the bulging that she had the visual loss. And I just want to know the temporal relationship between the visual loss and the bulging of the eyes. If there's any preceding events like trauma, or she had any surgeries in the past, neck surgeries in the past, or any form of eye surgeries or lid surgeries in the past, or any sinus surgeries or sinus abnormalities in the past. Also, like I said, any dental surgeries or any problem with her mouth. Now, just want to ask her questions with regards to tearing, redness, foreign body sensation, discharge. I think there's any discharge. What's the nature, mucoid, mucopurulent, or just normal serous discharge. Any sign of inflammation like pale redness surrounding eyelids, and if she has feels any warmth around the eye or any swelling around the eye, feels any swelling. And I asked her for other ocular associations like whooshing sounds in her ear, ringing sensations, tinnitus, headaches. She has runny nose, cough, catarrhs. The sinuses are very related to the eye, and abnormalities in the sinuses can cause ptosis, or like us about toothache, fever, chills, any changes in the appetite or weight loss, despite good appetite, any excessive or reduced bowel movement, excessive sweating, tremors, palpitations. These are all systemic features of hyperthyroidism that could be present in the patient. I just want to find out if she has any of this with regards to the bulging of the eyes. And if she feels that the bulging of the eyes worsens or increases with any valsalva maneuver when she goes to the toilet or when she strains or coughs. I'll ask her, and I want to take a few more detail about the visual loss. Was it sudden in onset? Was it gradual? Was there a true sudden loss of vision, or was it just a sudden realization that she lost vision in that eye? I would like to see the progression of visual loss. Was it rapid? Was it gradual? And what's the duration with regards to other symptoms that she had vis-a-vis the bulging of the eyes, and which one came first? So I'd like to ask her cheating at central or absent, or people, when it's at people's faces, if there's any covering in their faces. Is the visual loss worse at any time of the day or night? Does she have any previous transient visual obscurations, permanent or transient visual loss? And what's the pattern of this visual loss, as I already alluded earlier? So aside for floaters, flashes. Sir?
Sorry to interrupt. I'm enjoying the presentation, but please, for the benefit of our junior residents, when you mention any of the things you're inquiring about, could you just hint at the diagnosis that it could be appointed to, just to make, for the benefit of a junior resident, just to make it more complete?
All right. So, let's take note of that. So I asked her for flashes or floaters because she has visual loss. If she has any form of retinal detachment, usually they present with flashes of light because of traction on the retina. If she has any vitreous cells or vitreous debris, she can have floaters. Distortions in her images, is any macular problem or any problem in the ocular media, the cornea, the lens, any form of distortions can cause. She could have glare if she has cataract, because cataract is also a cause of visual loss. And I just want to be sure that she's 50-year-old, there's any form of glare in this patient. And blurring of vision, which improves with blinking. Patients who have bulgy eyes can have their cornea exposed and can have blurring of vision from evaporative dry eye or any form of dry eye syndrome, to be honest. And if they blink, that should improve. So I want to first find out if there's any symptoms of dry eyes and if any blurring of vision occurs when she has the drying of her cornea, any micropsia or macropsia, which would point out to a macular pathology. Just ask her for other relevant history, past ocular history. She has been to the doctor before, had any visual complaints. This is the first time. She has any history of glaucoma in the past to be relevant cases. Or surgeries in the past. Just ask her generally what her past ocular history is. Then the history of any autoimmune disease, particularly because we're considering the commonest cause of ptosis and ptosis in a middle-aged female is thyroid eye disease. And the commonest cause of thyroid eye disease, progressive bilateral or unilateral thyroid disease. And this thyroid is an autoimmune condition that can coexist with other autoimmune conditions. So I just want to ask if there's any history of that. I also think she has any history of hypertension or diabetes. Because one will see later in this discussion, we're going to treat her depending on what she has, but if she's going to be on any long-term steroid treatment, it might affect her blood pressure and blood sugar. And it might be very relevant to find out if she has any of these conditions, just to put it in the as baseline information. Also, peptic ulcer disease, all these three are going to be affected by long-term or high-dose steroid use. So it's important for us to just know if she has peptic ulcer disease or diabetes mellitus. And diabetes mellitus also, she could have retinopathy, which can worsen with some forms of treatment for ptosis. She could have radiotherapy in the future or radioactive iodine for any form of the cause of her ptosis. So it's important to just ask just any of these conditions. Then anti-hypertensives, anti-diabetics, just to confirm she has good control and how long she's been taking them and if she's regular with her follow-up visits. If she has any form of allergy, especially iodine, it would be nice to note that because she might be treated with any form of radioactive iodine, which she might be reacting to. And also, it's just generally to just find out because of some forms of contrast have iodine in them. We have to have the patients know about the allergies. So it's a family history of thyroid eye disease, glaucoma, or blindness. She's a female, definitely obstetric gynae will be very important. She won't have kids, she doesn't have kids, just as a baseline information. Then a very, very important history in this patient who has ptosis is smoking, because smoking is very, very important risk factor for development of one of the common causes of ptosis, which is thyroid eye disease. They say that smokers are about 2 to 3 times increased risk of having thyroid eye disease or Graves' disease in the first place. And also, if they have Graves' disease and they are smoking, they have like 800% increase or 8 times more likely to have thyroid eye disease. So it's important that smoking history is very important in this patient and what her hobbies are, because definitely her hobbies might be affected if she her vision is blurry. So I just like to review her systems, her general state of health, and know if she's just a healthy person or if she has any comorbidities. Then I'll just go straight ahead and examine this patient. Usually, we'll start with the vital signs, the temperature, the pressure, the pulse, and the respiratory rate to be sure that there is nothing. But usually, people who have hyperthyroidism have increased pulse rate more than 100 beats per minute. The respiratory rate could be higher than normal. So it's just good to just pay attention to those subtle signs that might suggest underlying hyperthyroidism. Her blood pressure is important, as I already alluded. She's hypertensive. It's also good to just know her blood control and just have an idea. Her general orientation is very important because you just want to know whether she's agitated or whether she's oriented in time, person, and place. Is there any neurological signs of space occupying lesion? Because any patient that presents with ptosis and diplopia is important. We just rule out neurological causes. Then the various signs of thyroid disease that also be important to rule out on general examination in this patient. Geoffroy sign is absence of frowning in a patient. So the patient is there's no upper eyelid crease or upper forehead crease. When it disappears completely and the person looks like he's just have a plain look. Stelwag sign, absence of frequent blinking in any person. Just pay attention to that because that will be very striking in some patients who have thyroid eye disease. Then the general examination, which is like pallor and cyanosis, where she's febrile. All these pallor will present if she has any underlying malignancy. Is the 3 A's, we call it anemia, asthenia, and anorexia. So she might be pale. If she has any underlying malignancy. So it's important to just take a look at that. Clubbing is also very important because it also tells us if she has thyroid disease, because clubbing, patients who have hyperthyroidism or Graves' disease can have some form of clubbing. Sweaty palms, tremors, perotibial myxedema, all very important because it also might show underlying the thyroid dysfunction, especially perotibial myxedema. And her lymph node examination is very important to know if she has any form of tumors or in any part of her body and metastasis to any part of her body, especially in this patient who has ptosis. So it's good to look at her lymph nodes to be sure she's doing okay. And the nodes are not palpably enlarged. Whether they are painful or tender will also be very important in this patient because inflammatory causes will cause painful lymph nodes, and non-inflammatory causes like tumors, metastasis will present more with painless lymph nodes. So good to look at the neck, any presence of any neck mass. We're already worried about thyroid eye disease in this patient. And thyroid disease can be, if thyroid state can be euthyroid, or it can be hyperthyroid or hypothyroid. So it's important to just examine the neck mass as we normally do for the location, size, tenderness. Swallowing is very important to see if it moves with swallowing. And just examine the nodularity of the mass and show if it's, because thyroid could be a thyrocarcinoma for all this work, to be a thyroid malignancy, or it could just be normal thyroid enlarged, which is just a goiter. So it's important to just examine the neck to be sure that everything is okay. If she has any neck scars, if she had any neck surgery in the past, like thyroidectomy, it will be important to just examine the neck very well. And examine do the nerve Ziegler sign. Let's just bend the head backwards and look at if there's any difference in proptosis from examining the patient. I just put it there because it's important to examine the neck from the back. Cardiovascular exam, very important to be sure everything is okay with regards to her heart rate, so because she might have palpitations and have some arrhythmias if she has hyperthyroidism. So it's good to just examine it real quick. Respiratory examination is most important because she might have increased respiratory rate. A good neuro exam is actually very important in this patient because she has diplopia, and the nerves that supply the eye are cranial nerves, and it's important to look at all the cranial nerves and see if there's any cranial nerve abnormality, because diplopia can be caused by cranial nerve 3 abnormalities, cranial nerve 4 abnormalities, and cranial nerve 6 abnormalities. The musculoskeletal system is also very important, especially for perotibial myxedema, as we already alluded to. So after examining her and gathering all my information from the general exam, I'll just do a visual function test by checking her visual acuity, distance, and near. Best corrected visual acuity, I'll refract her and make sure she's seeing okay and see what her vision is. Her vision could be normal, could be reduced, but I'll just take note of what the vision is. I'll do a color vision test and color desaturation test. I'll do a color plates, use the HRR or Ishihara test so that she can read all the plates out for me and see how many she gets out of it. If possible, I'd like to do a contrast to be sure that the visual, sometimes visual function, visual acuity may be normal, but visual contrast and color vision usually are said to be abnormal in early compressive optic neuropathies, which can coexist with our ptosis. So it's important to just look at color vision and be sure that everything is okay. Then a confrontational visual field will be a rough sketch to see what the visual field looks like. She has any form of scotomas, and just check the four quadrants roughly, and now check either static or dynamic. So just you put forth, you cover each eye like we do in the clinic, and ask the patient to look at your nose, and you test the 4 quadrants and test the center, and you move from out to in and out in all the 4 quadrants. See patients. So they're both static tests and dynamic tests for the confrontational. Some people have also tried to do color desaturation for the confrontational phase, bringing maybe dilating bottles with red covers from all directions. As the patient perceives the color saturation equally in all directions. That's also in the lag of ophthalmos is very key in this patient because we're considering thyroid as a possible differential for this patient. Lead retraction, which is also called the Rainbow sign. So lead retraction, the commonest cause of lead retraction is thyroid eye disease. And lead retraction is also the commonest presenting sign for thyroid eye disease. So it's very important with this history that they gave us, or the examination finding they gave us in the question. The patient had lead retraction. It's also important we look at how much of lead retraction the patient has by measuring the marginal reflex distance, as we're going to see when we're examining in the subsequent slides. But this is called the rainbow sign. The thyroid is a condition full of signs anyway. So permit me to just mention a few of them. There are over 25 signs, but I just mentioned like 12 of them in this presentation. So there's temporal flare. So there's temporal fullness due to increase in periorbital fat in patients who have thyroid disease. So that will be a pointer. And also patients who have lacrimal gland tumors can have that temporal flare, but to be indurated and painful and tender, depending on the etiology of the lacrimal gland abnormality. There could be fullness around the eye just from orbital fat increase in thyroid eye disease called vigorous sign. There could be erythema and edema just from severe orbital inflammation, which can be caused by any of the inflammatory causes of ptosis, which could be idiopathic orbital inflammation, orbital myositis, lacrimal gland infiltration and inflammations. And patients could have edema of the lids, and that would also be important to point out. Just there are all signs, non-specific signs of inflammation. Most inflammatory causes of ptosis will have all this. But cochlear sign, which is that stare that they have, scary stare, is very pathognomonic for thyroid eye disease. Von Graffi sign, which is lid lag or down gaze. So when the patient tries to look downward, the lid lags behind the globe as the patient look from straight eye gaze to down gaze, or from up gaze to down gaze, depending on how you want to see the sign. And if the lids are jerky when you look down, that's Boston sign. And if you try to lift the retracted eyelid, there's some resistance due to orbital fat infiltration and edema. That's called the Grovey sign. And there's an increase in skin lid. The skin of the lid is hyperpigmented or abnormal pigmentation. That's called the Gellenic sign. That's due to similarity between the melanotropic stimulating hormone and the thyroid hormone. Some similarities that causes the lid to have some hyperpigmentation. But this is not a very common sign in thyroid eye disease. It's not very common. There's difficulty in everting the upper eyelid, which is similar to Grove sign, but just that the person cannot evert the lid because the lid is swollen and sometimes tender. So, but important to also look at the patient's lid, because patient may have the lateral, bilateral lid involvement in thyroid disease, and they can have myasthenia gravis, or because of the lid retraction, it may be difficult to perceive or elicit the signs of myasthenia gravis. Say about 2% of patients who have thyroid disease may have coexisting myasthenia gravis. So it's good to just do a quick fatigability test to be sure that there's no myasthenia. And if there is a fatigability test is positive, they do a rest test or eye pattern if there's any change in the position of the eyelids. And then any discharge from either from complication of the exposure, like microbial keratitis, we need to check the discharge, the nature and the amount. The measurements are very, very important in this patient. As I said, the MRD1 can also help us determine how much of lid retraction the patient has. Usually when MRD1 is more than 5 meters of millimeters, then the patient is said to have lid retraction. And also, you can just grossly look at it. The eyelid position should be about 2 millimeters above the superior limbus, the upper eyelid, and just at the level of the lower limbus and the lower eyelid. So if there's any difference or any scleral show around that, that obviously means that the MRD1 and MRD2 are all increased. MRD1 is just the corneal light reflex measurement from the center of the cornea to the middle part of the upper eyelid, and the MRD2 is on the other direction. So MRD1 and MRD2 should add up to the peripheral height. So that also could be increased in patients who have thyroid eye disease. And good to just look at the elevator function of this patient to be sure. Usually it's usually normal in this patient. So after looking at the lid, you'll be look at the globe. This is where trying to systematically from outside to inward to examine this patient thoroughly to be sure we don't miss any thing. Alignment of this globe. Obviously, the patient has diplopia, and if it is binocular diplopia, there will be a problem with the alignment of the eye. So usually the intraocular circumference are most affected. There's a code for it, depending on how you want to remember, either from in to out, or you use I am slow. So inferior rectus is more affected than the medial rectus, then the superior rectus and lateral rectus is the least affected muscle. But it's important that we should know that the fact that the lateral rectus is least affected doesn't mean it cannot be affected. It can be affected. But when an eye is exotropic in thyroid eye disease, then we should pay attention that it could be caused by myasthenia gravis. Because myasthenia gravis mimics all forms of motility abnormalities. So it's good to do a diplopia chart in the 9 positions of gaze and see where the patient sees the double vision to help you type or locate the muscle that is affected. And the extraocular motility is very good in this patient. Force duction will help us see if there's any restrictive abnormality and identify the muscle that is restricted. And that will help us to know if it's a restrictive motility problem or a paralytic motility problem. The next ophthalmometer, I use the LUDs or the Hertels. More than 20, 15 to 20 is normal, but more than 20 is said to be abnormal. So it's better to just measure with a Hertel as ophthalmometer, but if we don't have that, we can just do regular LUDs and measure the keratoconal distance and see if how much proptosis the patient has. Since the patient already has proptosis. Then globe subluxation is when the anterior, the equator of the globe is in front of the orbital septum. So that's what it's called globe subluxation. You want to be sure, because globe subluxation carries a higher risk of especially keratopathy and optic nerve stretch. So that also is one of the causes or the new discovered causes of optic neuritis in patients who have severe proptosis, because the globe is subluxated forward. The natural the curvature of the optic nerve that helps prevent the stretching will reach this elastic point, and then now you could have some form of stretch optic neuropathy. It is required to palpate the orbital rim for any form of abnormalities in the orbital rim, suggesting trauma, or the contour is important. Lacrimal masses will be palpated in the temporal part. The proptosis we examine to see if it's axial or non-axial. That also give us if it's non-axial, pushing the eye not center, but any intraconal mass or muscle abnormality will push the eye forwards and cause a form of axial proptosis. It's good to check for the 6 P's, as they call them, pulsation and trills, because carotid cavernous sinus fistulas can present with progressive proptosis, and also it's important that you just palpate for pulsations or trills. Retropulsion, any form of conal mass will prevent retropulsion, and any mass that is not very soft will prevent retropulsion in patients who have proptosis. Tenderness is important because to tell us if there's an inflammatory cause. I will listen with the bell of our ophthalmoscope, the stethoscope, and see if there's any blue. It's important to check for Bell's phenomenon, because that also tells us the urgency to which we have to address the proptosis, because if the Bell's phenomenon is negative or absent, then it means that the cornea will be exposed when she sleeps at night, and we might want to do something about that and see if there's any increase in the proptosis with valsalva melanoma, because varices and orbital varices and orbital lymphangiomas will increase because of increased blood flow in the varices and the lymphangiomas with valsalva melanoma, and worsen the proptosis and make the proptosis come forward a little bit more. So do a cover-on-cover test to measure, actually with the prism cover test, to measure how more prisms deviation the patient has in all direction of gaze, because it's very important, because the temporizing measure before we do permanent treatment for diplopia in patients, because some conditions usually you require them to be stable before you go ahead to do surgery. So in the meantime, if you can prescribe prisms for them, but you need to measure it using on cover test, an alternate cover test, or prism cover test, as the case may be. So, sorry, that's it. So now it's also good to just electrochromas with some of the thyroid signs are also present that can give us an idea what's going on, like mobile sign, lack of convergence, ballet sign, any form of circular motility restriction is called ballet sign. I don't really know what they mean by that, but it seems like the guy just wants to put his name to the sign. Then, so the Suka sign is if the eye is fixed in adduction, like the eye seems like a fixes position medially, that's called the Suka sign. And if the globe is frozen and cannot move in all directions due to restriction of all the extraocular muscles, that is called Jandrisic sign. It's good to just look at if there's any form of abducting nystagmus, because multiple sclerosis can cause intranuclear hemiplegia and can present with visual loss and diplopia. So it's one of the differentials I would just want to take a look at. It's very rare in this patient because MS doesn't cause proptosis, but it's just good to look out for it, because as I said, a lot of things can coexist. So it's good to just look out for abducting nystagmus, which is probably be the only thing differentiating MS-induced INO from thyroid eye disease, because they both can cause optic nerve abnormalities and visual field problem and diplopia, but abducting nystagmus will differentiate INO caused by MS from thyroid eye disease. And up-gaze palsy, because the retraction is caused by paranoid syndrome, which is also called Duzami-Best syndrome. But it's also good to just look at, rule out if there's up-gaze palsy. But the paranoid syndrome or Duzami-Best syndrome had other features like lightness dissociation and convergence nystagmus. Convergence distraction nystagmus, which is absent in thyroid. So just if it's an up-gaze only, we'll just take a look and see if there's any abnormality with that. So the conjunctival sign is usually injected. When the conjunctival is very injected, it's called Gaucher sign. It's also a form of thyroid disease sign. Chemosis is just showing orbital inflammation. Engorged veins and alteration of the veins called corkscrew vessels will be more with CCF, whether direct or indirect. Episcleritis and scleritis are just inflammatory changes in the sclera and the episclera. So it's good to check the tear film assessment, tear breakup time, tear meniscus, because these patients who have proptosis can have some tear film abnormality. And if you reduce TF in less than 10 seconds or reduce tear meniscus, it's important to just note that down when we're managing this patient. So cornea will be examined thoroughly and stained. Everybody that has proptosis must be stained for any pointed erosions, ulcers, signs of exposure to keratopathy or infections, secondary bacterial infections, perforations. Corneal life is also important in measuring the angle of deviation. And keratoconus, I just put it there because progressive visual loss and diplopia can be caused by keratoconus. So just, but I don't really think it can cause proptosis, so it's not very relevant. But it's important to just know that you can check the cornea. And this is, people can have more than one pathology, so it's good to just look at the cornea very well. So do a gonioscopy, just be sure the angles are open. And then the pupil should be checked for relative apparent pupillary defect to show asymmetry, asymmetric optic nerve involvement. Then the knee sign is called uneven dilation of the pupils in demyelination, and Cohen sign. They're all thyroid eye signs. When they eject contraction of the pupil, when you're doing your light reflex. Check the lens for cataract, as I said. The visual should be normal, but the fundus can show a lot of changes. The optic nerve head can be normal, swollen, or pale, depending on what stage. So we should not be deceived by a normal optic nerve head. Compressive optic neuropathy can still occur in most causes of like thyroid eye disease in a normal looking optic nerve. Signs of glaucoma, because it's very rare, but it does occur if you like a 0.01% of patients who have thyroid can have signs of glaucoma. So they could be optic nerve cupping and typical changes of glaucomatous optic neuropathy. Pigmentary changes, pigmentary changes in the retina can give us a sign of chronic progressive hemiplegia or Kenset syndrome, which can cause progressive diplopia and visual loss. It's important to just look at the retina and be sure. Sean's choroidal folds, macular edema, all are rare findings in thyroid eye disease, but they can occur. So it's good to just look at them. Intraocular pressure in primary gaze and up gaze should be checked because differential IOP will show restriction of the muscles, and IOP can be high in patients who have thyroid disease. So if there's more than 6 millimeters of mercury difference in the IOP from the primary gaze to up gaze is also very significant for restrictive pathology. So based on all the history and ocular examination, general examination, I have these differentials listed out. So I could, most likely this patient probably has thyroid disease. Why? Because she's right for age, she's female. It's very common in females, about 6 times more common in females than in males. She's right age, middle age. Autoimmune diseases are more common between the 30 and 50 years bracket. She could have it coexisting with myasthenia gravis or just alone. But I mean, all the other signs, lead retraction, as I mentioned earlier, with proptosis. The commonest cause of lead retraction is thyroid disease, and thyroid disease, the commonest sign in thyroid disease is the lead retraction. So makes thyroid disease a most likely diagnosis. It could exist alone or with myasthenia gravis, or it could exist with second differential could be carotid cavernous sinus fistula, but that would not probably explain them. Would not be a very common cause. Bilateral, start with the left and the right. Direct carotid fistula, usually there will be history of preceding trauma, and sequential involvement is not very common in carotid cavernous sinus fistula unless it's slow flow and happens over time. But that could be a differential. There she will have whooshing sound, in her ears, and have the corkscrew vessels, as I mentioned earlier. And we could palpate a trill, or we could hear an audible bro to differentiate from thyroid disease as a cause of proptosis. Orbital myositis is also common. Gaze-evoked pain or movement is common in orbital myositis, but it rarely causes lead retraction because it doesn't really have much proptosis, but it can occur and it can cause proptosis. But that's also something that we should consider. Idiopathic orbital inflammation, which can involve any part of the orbit, orbital components, the fact the lacrimal glands and the muscles can cause, but it's a diagnosis of exclusion. And we have to rule out all the other causes before that will be our differential. But the eye will come in congested and there will be a lot of pain, and I look like a frozen globe without any sign of infection. Chronic progressive sign of hemiplegia is actually progressive bilateral, but there will be ptosis, there will be more of lead droop in this patient. So, but because it causes progressive diplopia, and it can cause, I just put it there because it can cause progressive visual loss, actually the cancer syndrome. So it's important to just take a look at that and be sure that she doesn't have that abnormality. And that can be ruled out it's a little bit an normal ECG if she has cancer syndrome, because cancer syndrome, they usually have a heart block. So, but orbital tumors, all orbital tumors, if I saw pictures of orbital mucosa which presents or look like thyroid eye disease, and or just on CT scan they picked it up and the patient was right age, and usually mucoses common in females also. Lacrimal gland tumors common in females also. She's a female, the right age. Lacrimal gland tumors between 30 and 50 years. So it's also important to just look at, but they should have non-axial proptosis in this other cause. Mucosa will be non-axial. Depending on the sinus involved, we could move the eye down and out if it's involved with another sinus. Or depending on the sinuses anyways. But MSI is the most common sinus. The lacrimal gland will move it down and in. So the lacrimal morphic adenoma is common as benign tumor of lacrimal gland and can cause proptosis in females. But the proptosis will be non-axial and she won't have much of lead retraction. And she will lack all the other thyroid eye signs. Cavernous hemangioma, common in females also, for 3 ratio to 1. She will have more of like axial proptosis, but she will lack all the thyroid eye signs, and there will be no systemic signs of hyperthyroidism. Tolosa-Hunt syndrome, painful condition in the orbital apex that can cause the eye to move forward and cause proptosis, direction of exclusion, and just inflammation at the orbital apex. But they cause vision loss, but it's rarely sequential and would be very least on my diagnosis. Those are maybe patients, as I said earlier, will cause up-gaze palsy and also lead retraction, but will not cause proptosis, and it's not just there because of lead retraction. Multiple sclerosis can cause in terms of ophthalmoplegia, as I said earlier. It can cause vision loss and progressive diplopia, and can involve the eye sequentially, but wouldn't have proptosis, so that will be very least on my differentials. So because of these differentials, I'd like to do a few investigations to hone in on my diagnosis and make a definitive diagnosis based on my investigations. So I'll rule out some of the conditions and also now manage the condition that I think is most likely. So I'll do a corneal scraping if she's developed microbial keratitis from exposure keratopathy and bacterial spore infection. I like to take a fundus photograph to see what the optic nerve looks like and what the retina looks like. The central visual field also help me examine the fundus findings as I listed before. Central visual field will help me to discover if there's any optic nerve neuropathy. Usually the common visual fields found in thyroid eye disease are circumcentral, paracentral scotomas. You could have arcuate scotomas rarely, but it's more of circumcentral. They're more of superior defects in the thyroid eye disease. OCT could show that cell loss, optic nerve change, typical of the visual field changes, and Hess chart could help us determine how long ago the person had the restrictive abnormality in extraocular muscles. Sometimes every other thing will be normal, but visual level potential will be depressed. The amplitude will be depressed in people who have compressive optic neuropathy like thyroid disease. Some people advocate using a VAP to just assess for optic nerve function, but it's not routinely performed. Baseline autophagy are very important because this patient is female. You want to see what she was like before she developed thyroid eye disease, because that will probably be your goal to treatment, because you want to make her look similar to what she was before she developed the symptoms. And that will be probably her most concern. So it helps guys the surgery and number when you want to assess pre-treatment and post-treatment for conditions like thyroid eye disease. It's important, or even orbital mucosa. It's important to achieving cosmetics for this patient who is female and of the right age. Baseline investigation like full blood count, liver function tests, fasting blood are very important, because in long-term steroids, people who have who use steroids above 8 grams cumulative dose will have liver failure. So you want to check that borderline or baseline liver function. Sorry, fasting blood sugar, as I said earlier, because you're going to do sugar monitoring. If you're going to treat a patient with thyroid disease, long-term steroid, you want to monitor the sugar and be sure the sugar is okay. She has diabetes, you want to control it, and probably place her on insulin while she's taking the IV prednisolone. Ultrasound will help us to see the differential involvement of the muscles, sparing the tendons, which is typical in thyroid eye disease. Also, this kind of the brain and orbit will help us to assess the orbital walls and the degree of the involvement of each of the muscles, and how even approach to surgery to help in that confirming the diagnosis, because orbital myositis will probably involve the tendon and the muscles, but the thyroid eye disease will spare the tendons. So we'll have a fusiform enlargement with sparing of the tendons, typically in thyroid eye disease. MRI will help us rule out all the causes of neurologic causes of diplopia. Actually, MS is very rare cause, but it can help us. And also help us to also confirm the diagnosis of the differential alignment of the muscle, sparing the tendon. ECG will help us rule out plagia if he has very good eye block. X-ray of parental sinuses or CT of parental sinuses also help us to rule out conditions that have to do with mucocele or things, masses lodging in the parental sinuses that might have causing ptosis. So diagnostic blood tests, I would like to request for our thyroid stimulating hormone, T3 and T4, just to be sure of our thyroid state, even though we can have thyroid disease in 6% of patients being euthyroid, but 90% of patients have hyperthyroidism, and it's important to just check what the thyroid function is. Thyroid antibodies like thyroid stimulating immunoglobulin, thyroid TSH receptor antibodies, thyroid peroxidase enzyme, thyroid binding inhibitory immunoglobulin, antimicrosomal antibodies, and myasthenia gravis antibodies are all important to be able to identify what is the antibodies that is most prevalent in the patients having thyroid eye disease, or if she has thyroid eye disease, to confirm the thyroid hyperthyroidism. So working diagnosis for my patient is thyroid eye disease, because as I said earlier, if it walks like a dog, screams like a dog, it is likely to be a dog. So we all have symptoms, and possibly the commonest presentation of lead retraction, she likely has thyroid eye disease. So I just want to give an overview of what thyroid eye disease is all about. I probably have said all this before during our discussion, but regards to epidemiology, I say 6:1. It can happen in a hypothyroid or in Hashimoto thyroiditis. About 90% of patients who have thyroid have Graves. There's always soft tissue swelling. We'll look at the pathogenesis in a few. I don't want to spend much time on pathogenesis, but we all have this examination that we'll all discuss in full detail. And it's just for us to just have an overview of thyroid as an entity. The only thing that's important in this patient is just to know that there's abnormal T3 in about 90% of patients. So about 10% of patients will have normal thyroid levels. And the diagnosis of large muscle sparing the tendon is also important in this patient. And the differential diagnosis, as we said before, the imaging will help us, the CT scan will help us, the differential between orbital masses and idiopathic optic inflammation and cardiac cavernous sinus fistula. Angiogram is very important also for CCF exclusion if the patient has CCF features. So this is the pathogenesis of thyroid eye disease, which I just want to mention briefly because I feel that it's important to have just understand the new changes in thyroid eye disease. What happens is that the orbital myofibroblasts are a very unique form of fibroblasts, especially in the body as against other myofibroblasts in other parts of the body. They express three important receptors which are very different from other fibroblasts in other parts of the body. They express this IGF, insulin-like growth factor 1 receptor, they express TSH receptor, and they express CD40R, which is seen on B cells only. So these fibroblasts in the orbits have been found to have these three important receptors, which have been implicated in the pathogenesis of thyroid eye disease. And the most recent one was the insulin-like growth factor receptor, which causes orbital fibroblasts to differentiate. And remember that orbital fibroblasts are neural crest cells. So they are neural crest cells, so they differentiate. They can differentiate to muscles and can differentiate to fat. So they can differentiate into muscle and fat, causes increase in fat content, and we will see in the course of our discussion as to why this is very important. So they can cause increase in hyaluronidase and galactosaminobutyric secretions, and all is just about binding to these receptors, TSH receptor and insulin-like growth factor receptor and CD20. This one is a bit a shouty picture. Sorry, let me see what they. Okay, so it's a very shouty picture, but it's just the basic thing about the molecular basis of thyroid disease, which is important. And like in every autoimmune condition, there's an antigen which recognized by an antigen-presenting cell. We present it to the T cell, and T cell will stimulate B cells to produce autoantibodies to destroy or stimulate, as the case may be. But in this case, the autoantibodies will go and bind on the fibroblast with these three receptors I mentioned, the IGF receptor and the tyrosine receptor, and cause it to produce inflammatory molecules and also secrete galactosaminobutyric or hyaluronidase, or differentiate into fats and muscle cell, which makes the muscle to increase about 8 times its size, and increase in fat component in the orbit, which is very new finding in kind of relatively new in thyroid disease, because in the surgery we will see why that is relevant. So, pathogenesis of late retraction, I just feel like it's important for us to just know why the eye is retracted in thyroid eye disease, sympathetic overstimulation, and the contraction and fibrosis of the inferior rectus and the corresponding secondary variation of the level of abdominal superiority will cause a retraction. The ptosis itself on its own will cause retraction, but these muscles contribute to significant retraction during the stage of the disease. The cause of visual loss in thyroid disease are very important. Dry eye syndrome, I've mentioned them so many times because of exudative keratopathy could be mild or severe, macrobial keratitis, corneal perforation, optic nerve compression, which can be due to arterial compression at the orbital apex or from stretching, and glaucoma. These are important things to just note for the junior residents who are going for exams, and manage them in part 1 exam. So the cause of ptosis in thyroid disease is also important to know that ptosis can occur in thyroid disease. It's not very common, but it can occur. So pseudotosis from contralateral ptosis, poneuritic ptosis from left papilla superior aponeurys, dehiscence or shaded MRC. And this fourth one, which is not very common but can occur, is due to orbital fat prolapse. And at the level of the orbital apex, we know that the corneal nerve enters the orbit to the superior orbital fissure and splits into superior and inferior divisions. So it can compress at that level from orbital fat compression. It can have a corneal nerve 3 palsy actually. So there are two phases of the disease called the Rondo's curve. There's an acute phase, which is about 1 to 3 years. The acute phase in non-smokers is about 1 year, but in smokers about 2 to 3 years. And the chronic phase is usually after 3 years in most people. So it's just important to just know this phase because they're important in management. Then there's this new entity called types of thyroid eye disease. There's type 1 thyroid eye disease and type 2 thyroid eye disease. Type 1 is predominantly fat hypertrophy, which is due to that stuff I mentioned about earlier in insulin-like growth factor causing just isolated fat hypertrophy with minimal circular muscle involvement. It's been characterized in different studies, but that is called a type 1. It's actually in younger people and usually white because it lacks the inflammatory component. And usually the eye is quiescent or will have thyroid disease. And this is very, very important to know. So type 2 is like more of circular muscles, and the one that is red hot with inflammatory components. And that's what is due to thyroid stimulating hormone receptor, and less of the fat hypertrophy, usually older patients, older than 40 years. So the severity of thyroiditis is very important in management. As we'll see in this patient, we don't even know what stage she is, but it's important to know whether she has mild, moderate, or severe. If she has mild, the treatment will be different, moderate, the treatment will be different, and side treatment will be different. So we want to know how severe is this thyroiditis. There's so many classifications, but I prefer the UGOGO because it's the European group on grave ophthalmopathy, because it involves quality of life and it kind of looks at the side-threatening complications of thyroid as against other classifications, which doesn't really mention side-threatening complications. This is just kind of a shouting slide, but it's important for us to just quickly pay attention to the right side of the slide, which is the clinical activity scoring system for UGOGO, which is very important. There are usually 7 symptoms and signs, or 7 points you want to measure, scoring 1 point for each at the first visit, and the last 3 are for subsequent visits. So if a patient scores more than 3, the patient is said to be having active thyroid disease. So it's all about inflammation. And if you look at it, it's very straightforward. Pain is a sign of inflammation, which is called rubor, dolor. So it's rubor pain, gaze evoked pain, that's pain of movement, eyelid swelling, redness, caruncular redness, swelling. And so each
Dr. Nwanko, sorry, I need to interrupt you.
All right. Sir.
How many slides do you have left?
There are only 40 slides. I don't know.
I can't see the numbering. And please, I think you should stay with the question. I don't think the question says you should come and discuss thyroid eye disease. Okay. Stay with the question, because you're not going to finish. You spent more than 1 hour already. Okay. You were supposed to spend 40 minutes, and then we use the other time for discussion. So when are we going to discuss? Please go to the, tell us what you are going to do for this patient. Okay, and then let's try and do discussion around the place.
All right. So the treatment plan for this patient involves certain approach. Endocrinologist managing systemic condition, managing anxiety, smoking cessation, and specific ocular management for this patient will depend on the activity of the disease, the nature, the severity of the disease, and the stability of the disease. Usually, the condition to be stable for 6 to 9 months before you can even do surgery. The thyroid of the patient is very important. Depends on blinding complication and the capacity of the hospital to manage these conditions, whether you want to refer them or not, is important in the patient. So basically, the mild condition is mainly treatment of dry eye disease. Moderate to severe condition, usually you want to treat any problem you have. But the one that concerns us in this patient is that the patient has visual loss. So it probably has severe. So we might want to do find out the cause of visual loss in this patient and treat the condition. For this patient, if the patient has optic competitive optic neuropathy, you might want to do orbital surgery, which can, the order of orbital surgery usually the orbital decompression surgery before the strapping surgery and for the eyelid surgery, because each of them have to be done in that order to help, because the other ones affect the lid position and the amount of deviation. So the complications are very straightforward: infection, hemorrhage. So the other non-surgical treatment for this patient will be hydrochlorothiazide for the lid edema, head elevation to also help at night, lubrication and patching if the patient has dry eyes. Then patching the eye for diplopia, depending when the patient is stable, will benefit from strapping surgery is also important. Fresnel prism, radioactive iodine, sometimes used to help ablate the thyroid in patients who are resistant to steroids. Radiation for thyroid is itself has been advocated, but it's also controversial. New treatment includes anti-CD20 B cell because of the role of CD20 and interleukin 6 and insulin factor 1. This teprotumumab is a very important drug and is a new drug been tried, and it's called Tepeza. It's said to even replace surgical decompression and helps reduce clinical activity score by up to 5 or 7, and also reduce ptosis by more than 4. So the newer treatment, surgical decompression, which can be 1 or 2, based on what I discussed earlier, and transnasal endoscopic balance wall decompression 24 to 26, deep lateral wall, and these newer surgeries, real-time MRI guided surgery, and so all real-time surgeries that help to guide the surgeon. So the bad prognostic factor for thyroid disease age more than 40 years. Our patient is 50, so she has bad prognosis based on her age. If she was male, so she has good prognosis because she's female, and we don't know her race. So, but if she was an Asian, she'll have worse prognosis. Smoking will worsen the prognosis and the nature of the disease. But if she was hyper or hypothyroid, also important. But if she was euthyroid, the prognosis will be good. Pre-TDR mixed edema and high autoantibody, especially TSI, are correlated with poor prognosis. Treatment with iodine, poor prognosis. So I would like to follow up, monitor the disease progression, watch out for combination of therapy use, watch out for flare-up, follow radiotherapy, and monitor for signs of depression, because it's actually a depressing condition. So in conclusion, thyroid disease is a self-limiting condition with grave visual consequences and can affect quality of life significantly. Multidisciplinary approach is the standard of care, can coexist with other autoimmune conditions. So a high incidence of substitution is very essential. Local data in UATH is not available, but occasionally thyroid patients present to us every year. So thank you all for listening, and these are my bibliography.
All right, thank you very much, Dr. Wako. Well done. That was very extensive. It shows you have a very robust base of the understanding of the disease. But as I said earlier, I think when you started discussing the thyroid eye disease itself, I think, that was when you started derailing. I enjoyed the earlier part, and then, when it now came to, okay, you've chosen that, okay, this is your diagnosis. You should tell us how you are going to manage that patient. Anyway, thank you very much. Let's listen to comments from the residents. It's a full house, although initially, I don't know, like many of them could not join. It's a full house now, so let's listen to them. You can send in your question if you can, or raise up your hand so that the host will recognize you, or you send in your question, please. Residents, is it that everything is very clear, or Dr. Wako has bamboozled all of you? Okay, so maybe in future we can send in our questions even when before the end of the presentation, so that will help. All right. Somebody wanted to talk?
Yes, good morning, sir.
Yes, Dr. Kalambi.
Thank you very much, Dr. Wako, for your presentation. As Oga has pointed out, very, very extensive. But again, seriously, you need to remember to stick to the questions, especially for you residents. You only have like 30 minutes to answer this question in exam. So the vital things are the things that are important, and try to maintain the flow and not derail. Initially, as you said, I enjoyed the beginning part of it quite well, but you were going back and forth at some of the symptoms and repeating lots of things. So, for example, when you were talking about the associated symptoms before, you now talked about possible etiology, and you talked about weight loss, and then you came back again and talked about associated symptoms again, going back to etiology. So there's a little bit of back and forth around the history, and I felt that took a lot of your time as well. And just remember to let it flow as you go along. Thank you. And then always remember the question. You always have a tendency of drifting away from the question that you're asked. So just be mindful of that. Thank you.
Okay. Dr. Wako, there are some questions there. Maybe you can look at them.
Yeah, I'm looking at it. All right. Thank you, Dr. Aisha, for your comment. Noted. Just felt the issue just to, since it was a clinical presentation, I've already answered the question in the first part. So the other one was just to enlighten us on what's new about thyroid disease. So we'll just, and they're all 40 slides, not more than 40 slides. So I was trying to rush, so I won't take time, but eventually it took longer. And your comment about the order of the associated symptoms was noted, but just wanted to ask them in relation to the presenting complaint here, so it will be easier to understand. But I get your point, it's valid. Yeah, thank you. So, yeah, Joma said I should please shed more light on the UGOGO classification and what is CAS system 1 to 10. So the CAS system is a clinical activity scoring system. There are 7 signs of inflammation, symptoms and signs of inflammation that are usually chosen, and presence of each one is called 1 point at the first visit. When a person comes the second time, then you now want to know if the patient is getting worse by if there is change in the visual acuity, and the other 3 things we now score extra 1 each. So, for example, if the patient comes and just has spontaneous pain, you score 1. Pain and eye movement, you score 1. If there's redness around the eye, you score 1. If there's swelling, you score 1. So you score all of them 1 point each. And if his clinical activity score is more than 3, you say 4 or more, then the patient has active disease. And it also helps in management of the patient to know the patient is improving. Follow-up visit, you want to see patients improving. The other ones for follow-up visits are very important because if the patient, it shows optic nerve involvement or worsening of the vision, decline in visual acuity. You want to know the patient is improving in visual acuity or getting worse despite your treatment. So the patient has competitive neuropathy. You want to try steroids first and see if the patient will get better or they will improve in visual acuity line. So that's why it's very important in the classification. And that's why I prefer it to the other no specs and then which are also there, but we didn't have time to discuss it. Because this one not just helps with the quality of life, as what was the major reason it was discovered, also helps in management and prognosis. So that's what it's all about. So would it be in order to, if one has a slide on possible working before looking the history? Well, it's just about answering the question too. I mean, I try to follow the normal order in medical school, so list the differentials after I must have examined the patient. I thought about doing it in the beginning, but I felt that this is a better approach. And this is just my own approach. You guys can say what they think, but I just felt like this is my own approach. It might be wrong, but maybe the contact will help us with that question, whether it should come before or after. But I don't really know, to be honest. So is it in order to also to roll out hypothyroidism as well in the history? Yeah, it's important to me, but 90% of patients have hyperthyroidism and 6% are euthyroid. Only less than 4% have hypothyroidism. But pretty Bram's edema can also show, and change in bowel movement can also help you. It's also ways that erode hypothyroidism because increase in bowel movement will be hyper, reduce will be hypo. So they can be vice versa, but they also, I try to rule them out in the question. But you're also right, it's rare, but can happen. Patient can be hypothyroid. In this patient, I was wondering if vision would be essential, limited to the most likely diagnosis. Is it routine to do CT? Well, the literature says that you should do the antibodies and at least either of CT scan, because some people feel like the diagnosis of thyroiditis has to be two out of 3. But there's a AO classification that says you must have to, either you have the orbital signs and symptoms of thyroid disease with epidemiological evidence or orbital signs with radiological evidence. So some people want to do the 3 of them so they can have 2/3 or 3/3 and make sure they have thyroiditis. And also, I saw a patient who had mucocele in one of the case reports, and the patient had all the things looking like thyroid disease, and the patient would have missed if they didn't do a CT scan because the patient had a mucocele. So it was right age and everything. So it's important to just do a CT scan because you don't know what they're going to find. And the patient involvement of the muscle, sparing the tendon, is also very important because you cannot see that on clinical exam. And other differentials may have things that look like thyroid disease in a euthyroid patient, because these are even more important in euthyroid conditions. So that's why it's important to do the investigation. Now, the tutorial for the interim, I mentioned it as one of the non-surgical treatments. You can patch the eye, either a scotch tape in the glasses, you can patch the eye, pad the eye to reduce diplopia. Usually that, or give prisms if the person has stable, you can do that in the interim. Sometimes they give Botox injection, to help with the diplopia, to release the restricted muscle. But I mentioned it in the discussion. I'll just rush in too fast because I spent too much time. What is the role of counseling? Yeah, counseling is very important, especially as I said, I mentioned in the slide also, the team management, and there will be a psychologist, because I read somewhere that the quality of life for thyroid disease patients has reduced a patient who have breast cancer, and the suicide rate in patients who have thyroid in the US is about 7%. So they can commit suicide because they disfigured. There was a woman who had died after her wedding and she committed suicide. So counseling is very key and psychology is very key. And co-management with the general surgeon. I already said before that if you have neck scars, it just depends on if the patient has hyperthyroidism or obvious goiter. But yes, it's a multiple disciplinary approach, and it's important to involve the general surgeon if you see that the person has goiter. So just to add, okay, so she's just making a comment that gynecological history is important in thyroid eye disease. Please, how long will you wait for the strabismus surgery? Sorry. Usually, different books say different things, but in the long run, it's 6 to 12 months. Some people say 6 months, some people say 9 months, some people say 12 months, but it's usually when the division is stable. If you record stable measurements in 2 or more visits, then it will be right to do the strabismus surgery. That's after you've done the orbital decompression. But with the new treatment of PISA, that's the protumoral, you don't really need to do the decompression surgeries as you will use, because that will help before you do the strabismus surgery. So strabismus is stable for 6 to 12 months. You can do your surgery for strabismus. What are the principles of orbital decompression and the approach? The principle of orbital decompression is, as I said before, different wall, depending on how much ptosis the person has. The patient has 4, between 20 and 24. You want to do like orbital fat wall decompression, because that will probably reduce it to about 6 months. So if you do a balanced, somebody's echoing, I don't know, and mute your microphone, please. So if you do like a balanced wall decompression, it can be transnasal or endoscopic. But if you do a medial wall and lateral wall decompression, then you reduce the risk of injuring the infraorbital nerve, and that also is very important. It's very on degree of, so for mild proptosis between 20 and 24, you do 1 wall. For moderate proptosis between 24 and 26, you do 2 wall. And for severe proptosis more than 26, you do a 3 wall. But people have combined fat decompression with either of these 1 wall and have found significant improvements, especially in type 1 thyroid eye disease. So people are beginning to do more fat decompression using sinus surgery and now treat with teprotumumab and see if the patient improves. So yes, the goal of surgery is to reduce the amount of protrusion and help reduce the complications of proptosis. Please, why would you ask history of dental infection? Well, history of dental surgeries, just to make sure we're not missing, the orbital cellulitis is the cause of proptosis, and you want to see the previous dental issues are all relevant in this patient. Please, is the CNS examination like checking for reflexes relevant? The CNS examination with regards to checking the reflexes might be, it's just because of the, when we're taking the history, we don't know what the patient has, even though we might know what the likely thing is, but it's good to just do a full exam. But we'll pay more attention to the ocular exam when you're doing the CNS exam, because it's more of proptosis and diplopia, and the ocular corneal nerves are what are involved mainly. But multiple sclerosis can cause a lot of changes in the rest of the neuro exam, so it's important to just check, because that can be a cause of diplopia, progressive diplopia, and also in patients. So it might not be very, very relevant, but it's just take 4 minutes to do a neuro exam, so you can do it if you want. You don't seem to have pictures to show most of the science, because I had to sit to 40 slides and I want to answer the question, so I couldn't put pictures. I had to squeeze in, summarize them as much as possible, and make the slides not to be crowded. That's why I didn't have pictures. I'm sorry about that. I noticed that your differential is also including lateral causes, considering the fact that you were given a question that both eye was involved. If a patient has moderate severe, how would you treat? Yes, differentials diagnosis, nothing says that those conditions cannot cause bilateral causes, but they are rare. But I just mentioned them because it's good for us to just know that there are other things that can cause progressive proptosis, even if it's unilateral. But sometimes those things can happen bilaterally, just that they are more common unilaterally. So that's why I mentioned some of those causes. If a patient has moderate, how would you treat this patient? If I have moderate to severe proptosis, the quality of life is just to check the clinical activity score at the stage, and then to and then to what do you call it? Yes, just that we're rushing. Yeah, but moderate to severe cases, there are medical treatment and non-medical treatment. Despite the dry eye syndrome part, you can use lubrication, you can use goggles that help to prevent evaporation, the water goggles, just help relieve the discomfort. And as I said, there's a new drug, also many new drugs like rituximab and tepotumab that are very good for moderate to severe thyroid eye disease, which are not sight-threatening, and help reduce the orbital inflammation significantly. And they're actually the way people are treating thyroid eye disease right now, because it's very, very expensive and it involves infusions every 3 weeks, 8 infusions every 3 weeks. But the phase 3 randomized control trial showed that the quality of life was very good, and the TSI dropped, and the clinical activity score really improved in patients who were doing tepotumab. So that would be one of the ways to go. And monitoring the patient is very key, because the patient can become fibrotic and develop stricture fibrosis, and we need orbital decompression if there's signs of orbital compromise. So I mentioned that in my discussion. If the patient is euthyroid and you're the first dosing, what if the patient, as I said, if the patient you tried, I want to do a orbital orbital CT to be sure that the patient doesn't have any other condition, because euthyroid condition, the thyroid will be normal, so you might want to just check if there's nothing you are missing. So thyroid, so CT scan will be helpful to rule out the differentials, and if everything is fine, you just look at what the patient is complaining about, at what stage the patient is, and what his clinical activity score. If it's in the active phase or the first 1 year, it's important to just ask the patient smoking, stop smoking, lifestyle modification, treat the dry eye syndrome, lubrication, contact plugs if the dry eye is really bad, then give some, treat the dry eye if dry is very bad. Basically, that will be what we'll be doing for that patient. And if you can patch the patient till the patient's the vision is stable, then you can now do surgery when the patient is strabismus or whatever after 6 to 9 months stabilizes. So, and just follow the other orbital decompression first, there's strabismus surgery, then eyelid. The eyelid surgeries are also important. I didn't really go there, but they're in the chart. Monorectomy and lateral levator papillary superior recession also surgeries that can be done for lead retraction. So they can be used to many sites. But if a patient, even if it's I would definitely involve the endocrinologist and also the psychologist and the general surgeon, as already discussed. So please, is orbital cellulitis. Orbital cellulitis is the differential for ptosis all the time, but the problem is that in this patient, it's bilateral and sequential. It is going to be very uncommon to have bilateral sequential orbital cellulitis. It can occur, but with the history we're given, it's more likely that the patient has thyroid disease, but it is a differential, and I try to read out in my questions. So let me see if there's any question in the chats. I saw a Jairus question right here. I didn't forget to mention ptosis, but I spent plenty of time discussing ptosis in my discussion. So even examination MRD1 and MRD2, I mentioned all that in the ptosis discussions, because I even mentioned cause of ptosis in thyroid eye disease. There was a separate slide on it. So I didn't forget ptosis. I mentioned ptosis. I didn't also mention symptoms of myasthenia. I did mention symptoms of myasthenia, fatigability, swelling in the eyelids. I did mention it. I said 2%. I didn't say 80%. I said 2% of patients who have thyroid disease have myasthenia gravis. Sorry. If I said 80, I meant 2%. I didn't mean 80. I'm not sure I said 80. But if I did, I'm sorry. I said, I meant to say 2%. All right. So I think that's all the questions. I've taken all the comments, and thank you for your comments. And I appreciate your comments, and I wish if there are more questions, I'm writing them down too. So.
All right, Dr. Owanko, thank you very much. Well done. Can we listen to the panelists, Dr. Azogu, and then after that, Dr. Chiari will also help us round up. Thank you.
Well done, Dr. Nwako.
Thank you, sir.
I'm really impressed with the amount of knowledge you have on the subject. I was hoping to see a little emphasis on orbital apex syndrome. You mentioned some of the etiologies that may cause orbital apex, but anytime there is external ophthalmoplegia and visual loss, one should always entertain orbital apex syndrome. Yes, and there are so many entities under that that can be considered. I don't know whether I gave it any thoughts.
Yes, I missed mentioning about trying to pick out some of the entities that will cause orbital apex abnormalities. But yes, I agree with you, sir. The orbital apex syndrome is a differential in this patient. Yes.
Please, maybe next time you help us number your slides so that we can make reference.
Yes. Yes. Yeah. Sorry. Yes.
Thank you very much.
Thank you, sir.
Thank you, sir.
Please, is Dr. Kiari with us?
Hello, good morning once again.
Good morning.
Good morning. Yes.
Dr. Wanko, thank you very much for this very
Thank you, ma'am.
extensive and enlightening presentation. And I can see your depth of knowledge, which is quite good and it's encouraging. But just, okay, on the manner of presentation, yes, number your slides. One of, not only one, slide 2. I want 1 of 40, 2 of 40, so that we know which stage we are at. And then really keeping presentation to time is an art that we must all learn. We have to be able to, there's so much information, wealth of information all over the place, but we have to bear in mind that we cannot say everything that we know or everything that there is. So it is an art to know what to present. And, if people are not clear, they can always ask questions afterwards. So let's all try to learn how to present within time. One day you'll be called to present in 3 minutes. Your entire career or what you have done, you'll be called to present it in 3 minutes and you should be able to do that. So let's try and make that an art. Orbital diseases, I just for the residents' sake, there's a ballpark way of checking, of examining. We have the 6 Ps, which we should check. It's all littered in some of your diagrams and everything, but we should note pain, proptosis, progression, palpation, and retropulsion, and then pulsation and periorbital changes. So whenever we're looking at orbital diseases, we should make sure that we go systematically to that. That said, before we round up, Dr. Ayeni.
Yes, ma'am.
Please, I'd like to do a poll.
Okay.
Which is going to take just 3 minutes or so. Can you see it now?
Yes, ma'am.
So it's answer, you can answer all. I mean, just if it's correct, say yes to all the questions. Lead retraction can be caused by aberrant regeneration of the third nerve. If it's yes, you just say yes. Liver cirrhosis, if it's yes, you say yes. If it's no, you say no. Collier's sign in Parinode syndrome, uremia, eyelid trauma. Dr. Wako has mentioned some of these causes of lead retraction, and he dispelled it in his discussion. So I would like to see. You can carry on to vote. Can you vote? Are you voting? Is anyone voting? I can't see anyone voting.
Okay.
Can you see the poll on the screen?
It's like it's only the resident you want them to look at it, have you?
Somehow panelists cannot vote. Let me see if they can. I don't know why. But the residents are not voting. Are they not there? One person.
The resident, there are 12 of them that are still on.
I can only see one person, one of 12. Have they left? The screen is blank. Oh, did someone? Okay.
Yeah, they are there. It's just maybe it's taking time to.
Okay, it's coming up now. Good.
Mm.
So the second question is bilateral proptosis may be caused by, and then I have this. Pulsating proptosis may be caused by. So it's just to draw your attention to some of the unusual causes or some of the things that we might think they are, even if they're not. Seven out of 12 have voted. 9 out of 12. Okay, I have 10 now. Ten out of 12. I'll just give a few more minutes. Okay, 11 out of 12. Let's see if one last person is going to vote. Okay, I'll just stop here. 11 out of 12 have voted. So I'm going to share the results. Out of 11. So lid retraction can be caused by, actually, all these causes: aberrant regeneration, liver cirrhosis, Collier sign and Parinode syndrome, uremia, eyelid trauma can all cause lid retraction. So I expected 100%. I didn't get 100%, but these are all causes of lid retraction. Important to know, very important in multiple choice questions, especially if you're going to do any of these international examinations. They go down to this level, or they go up to this level. Bilateral proptosis may be caused by cavernous sinus thrombosis, leukemia, congestive cardiac failure, thyroid-related inflammatory orbitopathy. I got 100% there, obviously, and we just finished talking about it. Metastatic neuroblastoma. All of these, again, can cause bilateral proptosis. Important to know. Pulsating proptosis may be caused by, yeah, so proptosis may be pulsating. I don't know, Dr. Wako, did you address pulsation?
I did.
Yeah, you did. Frontal mucocele, meningocele, meningoencephalocele, dural arteriosclerosis, venous fistula. So again, all of these can cause pulsating proptosis. So actually, all the answers are should be 100%. All right. Just to make a note of that. So when you see an obvious diagnosis of thyroid eye disease, look for something else. Be able to be ready to discuss all the other things. All right.
All right.
Okay. So thank you very much.
Right.
I have no further comments.
Thank you very much, ma'am.
Thank you, ma'am.
I want to thank everybody, all the participants who made out time to attend our webinar today. And I want to thank Dr. Wanko too. I think your depth of knowledge is an encouragement to the other residents. They should know that it's doable and aspire to also have that kind of depth. Okay, so I challenge all of them to really work towards that. So I want to thank all the panelists too.
Thank you, sir.
and our hosts, the Eye Focus, we are grateful. I want to use this opportunity to congratulate our Muslim brethren for the successful completion of the Ramadan period, and I want to say happy celebration in advance. So let's all have a nice day. Thank you very much.
Thank you, sir.
Thank you very much.
Thank you, sir.